Hey everybody, welcome back to Pharmacology. Today we'll go through the adrenergic drugs. So the catecholamines are going to be epinephrine and norepinephrine. The endogenous would be norepinephrine, it's a neurotransmitter. Epinephrine is a neurohormone, so this has a shorter and more local effect. This has a longer and more systemic effect. Dopamine is going to be our neurotransmitter as well, and synthetic catecholamines are going to be isoproterenol, dobutamine, and phenoldopam. Anything that ends with dopam is going to be dopamine. Phenylalanine is the precursor of all of the catecholamines, so it's important to know that phenylalanine goes to tyrosine, and then dopamine is the precursor to norepinephrine, and then epinephrine. So only epinephrine and norepinephrine to epinephrine is going to be made in the adrenal glands. The rest can be made in the CNS or other neurons. Okay, so everything is broken down by either COMT or MAO, and we end up with hydroxymandelic acid, which eventually metabolizes into vanillomandelic acid and homovanillic acid in urine. These are important because very, very high levels of both are indications of either a cholinergic crisis or pheochromocytoma. MAO-A will metabolize norepinephrine, serotonin, and tyramine. MAO-B will metabolize dopamine. So right here, MAO blocks the reuptake into the vesicles. These other medications, so metirosine will block the rate-limiting step. So that's going to prevent tyrosine hydroxylase to go to dopamine, etc., etc. Guanethidine is going to prevent the exocytosis of the vesicle, so no neurotransmitter will be released. Adrenergic agonists or antagonists are going to work on the receptors. Cocaine or tricyclic antidepressants are going to prevent the reuptake. And reserpine is going to prevent the norepinephrine going back into the vesicles. So isoproterenol has no alpha receptor action. Epinephrine has no beta 3 receptor action, though beta 3 is pretty rare. And dopamine is going to work on the D1 receptors in the kidneys. Alpha 1 works with the vasoconstriction, increases blood pressure. That's kind of all you want to know. Alpha 2 is going to inhibit norepi and acetylcholine release. It's going to inhibit insulin release. This is important to keep in mind. Beta 1 works in the heart, so it's going to increase the cardiac output. Beta 2 is going to work on the systemic vessels, so it's going to decrease the peripheral resistance. It's going to increase glycogenolysis. So these two work together. Alpha 1 is going to inhibit insulin. This is going to increase glycogen, increase glucagon, increase smooth muscle relaxant. So that's going to work with the vasodilation. Okay, so once again, Alpha 1, smooth muscles, contraction. Alpha 2, it's going to decrease neurotransmitter release. Beta 1, increase cardiac output. Beta 2, bronchodilation, vasodilation, works against the alpha 1 receptors. Beta 3, like I said, is not that important because they work mainly on the adipocytes. And D1 are going to be in your renal blood vessels, and when they are stimulated, it's going to react with vasodilation. Direct-acting are going to be working directly on the receptor, either to binding directly to the receptor. The alpha agonist, the non-selective one is going to be norepinephrine. Alpha 1 selective is going to be phenylephrine. Alpha 2 selective is going to be clonidine. Clonidine is one of the drugs we're congestive heart failure. Beta agonist, the non-selective, is isoproterenol. Can't use this in people with COPD. You can't use this in people with asthma. Beta 1 selective is going to be dobutamine, good for anybody suffering from cardiac failure. Beta 2 selective is going to be albuterol. And the mixed action or non-selective, the ones that work on both beta the receptors, are going to be epinephrine and norepinephrine. The indirect acting agonists are going to release norepinephrine from the receptors, and they are ephedrine or amphetamine. The reuptake inhibitor is going to be cocaine or the tricyclic antidepressants. So the greatest clinically used drugs are going to be the direct-acting drugs. So it's either going to be the beta agonist or the beta agonist or the alpha agonist. Okay, so the vasoconstrictors are going to be phenylephrine, norepinephrine, ephedrine, and methoxamine. The cardiac stimulants, so the important ones to know are the dobutamine, ephedrine, and isoproterenol. These are going to increase the cardiac workload. They're going to increase contractility, increase heart rate. Bronchodilators, albuterol, salmeterol, terbutaline. They're going to help in allergic reactions. They're going to work with people with COPD. Nasal decongestants, phenylephrine or xylometazoline is going to be used in allergic reactions. CNS stimulants, amphetamines, these are really used for narcolepsy, ADHD. These are controlled substances for sure, but more often than not, they are abused. Uterine relaxants, ritodrine, isosuprine, and terbutaline are going to help induce labor. Anorectics, fenfluramine, and phentermine. These are new drugs, and they are used to stimulate appetite. They're going to help decrease the insulin. Increase this insulin sensitivity. They're going to decrease the amount of glucagon available, so they're going to help these patients gain weight and keep the weight on. Okay, so direct-acting alpha-1 agonists are going to increase the total peripheral resistance, increase the blood pressure, but there's no change in pulse pressure. So there is less cardiac output because there's the reflex bradycardia. Alpha-2 agonists are going to increase the sympathetic outflow. So on low doses of direct-acting drugs, there's first going to be low heart rate or slow heart rate. After you give some more clonidine and methyl dopa, they're going to increase the blood pressure. So they're going to increase the sympathetic activity. Methyl dopa is also approved to treat gestational hypertension. And the alpha-2 agonists can't be stopped suddenly because they decrease the sympathetic outflow, and taking them away is going to have the reflex tachycardia, so then it results in sudden cardiac death. Tizanidine is an antispasmodic. You use it to treat epilepsy, seizures, and dexmedetomidine. We use that actually as a sedating agent. You use it right before surgery. Okay, so beta-1 agonist, dobutamine, treats congestive heart failure. Beta-2 agonist, all of these will treat bronchial asthma and COPD because this one affects the heart, this one affects the peripheral vessels and the lungs. Ritodrine and terbutaline relax the uterine muscles to induce labor. And then the mixed beta agonist, isoproterenol, is going to have both cardiac and pulmonary effects. Mixed alpha and beta agonist, norepinephrine, is going to increase total peripheral resistance, blood pressure, heart rate, cardiac output, all of this good stuff. And there's a monophasic response on blood pressure. So it's going to have one effect. Mixed alpha and beta agonist epinephrine has similar effects, except they decrease the total peripheral resistance and the blood pressure, and it also inhibits insulin secretion. This one has a biphasic response, so there's going to be like first a rise in blood pressure and then a drop in blood pressure. Because on low doses it only works on the beta receptors, but on higher doses it works on the alpha receptors. So at first it slows down the heart thanks to the beta 1 receptors, and then once it starts working on the alpha receptors, constricting all the blood vessels, the heart compensates, and then blood pressure rises. Unfortunately, you can't use this for a long time because it will result in the receptor desensitization, which is very different from just like desensitization is different from just like getting used to the drug. We'll go through that a little bit more, but bear with me. Okay, so the vasomotor reversal DAO works with the biphasic response, right? So this is also given as a reversal for epinephrine, and epinephrine is given as a reversal because you want to give them high dose epi at first. The alpha 1 effects are going to predominate, so there's going to be the vasoconstriction, and then as it gets metabolized, there's the beta 2 reaction. So in order to prevent all this, use an alpha 1 blocker, so the only thing left is going to be a drop in blood pressure. So we want to use that in cardiac arrest, in vasoconstriction, hypotension, anaphylaxis or asthma. Dopamine is going to be an adrenergic agonist as well. It's the most sensitive. First is dopamine, and then the beta 1 receptor, and then the alpha 1 receptors. So at low doses, it will dilate the renal blood vessel and then increase the glomerular filtration rate. At high doses, it's going to affect the heart because first this, then this, then this. And then at the largest dose is going to work on the alpha 1 receptors to vasoconstrict. So the most commonly used dose is just to raise the cardiac output and the systolic blood pressure. So we use that to treat a congestive heart failure or septic shock. So we want the heart to work more efficiently in congestive heart failure, to reduce the edema, and to actually perfuse the organs. In septic shock, there is going to be hypoperfusion systemically, so of course we want to raise the blood pressure. Phenoldiazepam is going to be used in the hypertensive emergency to bring down the blood pressure, but not too quickly. There is a system of doing so, because if you lower the blood pressure too fast, there's going to be hypoperfusion to the brain, and that can lead to coma. Butamine is a derivative of dopamine, but there's no D1 or D2 agonist action. It only works on the alpha and beta receptors, and the clinically used dose is going to be used to increase the cardiac output, but there's no change in heart rate and blood pressure, so it's going to work on the contractility of the heart. It's a relatively selective beta 1 agonist, and it's an inotropic agent in severe congestive heart failure, so contractility. Okay, so this is what I was talking about. Tachyphylaxis versus tolerance. The indirect adrenergic agonists releasers are ephedrine and amphetamine. This is a nice little mnemonic ear. Ephedrine is going to increase the release of norepinephrine, and that's going to lead to hypotension. So over time, it will induce the effect, which is tachyphylaxis, which is a decrease in response. And it's like with each dose, the response is decreased because it displaces the norepinephrine from the storage vesicles and releases norepinephrine until eventually it runs out after, like, let's say dose 4. Tolerance is different because this is the dose administration over time, and it's not like it just goes down to 0 and then another one and another one. And intolerance, this is gradual. You can't like start over. For ephedrine, to kind of prevent the tachyphylaxis, we just stop giving it, and then we restart it after a certain amount of time, like 24, 48 hours. So the response would be like similar to dose 1, dose 2. Amphetamines are going to be releasing norepinephrine, dopamine, serotonin, used to treat narcolepsy and ADHD, as I said before, because they are stimulants. So this is the example, methylphenidate, and the reuptake inhibitors, cocaine, and the tricyclic antidepressants. This is an important clinical note. Denervated effector tissues are going to be non-responsive to indirect acting sympathomimetic drugs. Okay, so contraindications, we can't use it in ischemic heart disease, hypertension, diabetes mellitus, pheochromocytoma, and hyperthyroidism. Why? We don't want to contract the heart anymore. This is going to lead to heart failure. We don't want to do vasoconstriction. The heart is already failing. We don't want to make it worse. Once again, vasoconstriction and hypertension, not a good idea. Diabetes, remember the alpha-2, it's going to decrease the insulin secretion. We don't want that. Pheochromocytoma, increase in the catecholamines. We don't need more. This person's already having too much in their system. Hyperthyroidism, so kind of similar with the diabetes. There's going to be increased glucose in the body anyway. We don't want to decrease the amount of insulin. The adverse drug reactions, there's going to be restlessness, palpitation, anxieties, and tremors, along with a marked rise in blood pressure. So with the marked rise in blood pressure, if you give it to anybody with ischemic heart failure or ischemic heart disease or hypertension, there's going to be an increased risk for a stroke or cardiac arrhythmias, which can also lead to strokes. That's it for now. Thank you for your attention and good luck studying.